Patient care is hard work. It
Mm-hmm.
is. And if you're doing it well, if you're engaged, if you're making eye contact, if you're listening, if you are using empathy, it's hard work.
Welcome to That's Derm Good. I'm Janelle Ball, and I'm excited to bring you thought-provoking conversations about biologics, specialty medications, treatments, and so much more. I'll be chatting with some amazing guests about access, affordability, and advocacy. You're really going to enjoy this show. Welcome to That's Derm Good. Today, my guest is Dr. Angela Lamb. Dr. Lamb is the Associate Professor of Dermatology at Mount Sinai. She's also the Vice Chair of Clinical Operations and Strategy. And I am so excited to have you on and chat with you, Dr. Lamb. Thank you for joining me.
Thank you for having me.
Yes. So you've got so many titles and had so many accomplishments. What got you into dermatology in the first place, and what inspired the passion to educate?
Mm-hmm. No, thank you. I'm just so honored and excited to be here. So first, why dermatology? I was actually just talking to a patient about this yesterday because I was like, I think some people think it's like a vanity career. So, they think, oh, it's going to be easy, or a couple hours a day. And that couldn't be farther from the truth. Good dermatologists, who, especially those that want to keep the lights on, they work incredibly hard. But the things that drew me to it, which actually are the same things that make it a difficult specialty, are that I love to talk. So I ruled out certain ones like radiology, anesthesiology. Like, I'm far too chatty for that. And actually my second specialty, so I co-applied. Dermatology is so competitive that my second choice was actually psychiatry. Like, that's how much I love to talk, love to listen as well, because I think that's part of being a good doctor. So those kind of natural skills and gifts I leaned into, a specialty that would give me those opportunities. I also love to do procedures. So I still do excisions. I trained in an amazing program where we got a world-class surgical training. So I still do excisions, but I also do cosmetic procedures, lasers, injectables, and have that eye too. Like, you could probably see my office. People have come to my home. I really like to curate and create nice spaces. And I do a lot of that outside of work. But in dermatology, you're able to do that because you really, from a visual standpoint, can, fix folks. People come in with bad atopic dermatitis, bad hair loss. They have some, moles they want removed cosmetically. And we really can take them from point A to point B, often in a relatively short period of time. And I love that, just that visual coming forward. So it really checked the boxes for many things. I loved science growing up. It was really one of the things that I was good at. And so, it brings all of that together. And then to answer your second part, the teaching aspect, before I went to medical school, I was actually an after-school program director. So I've always, from a young age, really loved kids, even though I do see children, even though I'm not board certified pediatric dermatologist, I see children. But in loving children, what I like is the wonder and the ability to teach and impress upon them ideas and thoughts. And the same kind of carries over into my practice. So if you come to see me, yes, I'm talking, yes, I'm listening, but I'm really trying to teach you about your skin, teach you how to take care of it, teach you integrative ways that you can incorporate to help your skin, whether it's your acne or your AD. And so all of those come together. And then the residents too. I really enjoy having the residents for the same reason. I like really teaching the next generation and helping them grow and build, not only in how I practice, but in how I take care of patients and how I speak to them and help get them the care that they need.
Yeah. So did you always know that you would be in a leadership position?
So it's funny. I would say no. Anyone that's known me a long time, like my husband who's known me since I was 17, would say like 110%. He would say like, oh, I'm not at all surprised. So it's interesting how other people sometimes know you better than you know yourself in some regards. So I think when I was going undergrad medical school, I just kind of thought maybe like I would practice, and I knew actually I never wanted to be in private practice, but I thought like, oh, I'd work in an academic setting, and then just the other leadership aspects, the operational vice chair things, the teaching parts, the access work, that all came, I think, just out of some of my desires to lead with integrity. I think that I was inspired kind of seeing how I was, unhappy with how certain things were done or being done. I say this with all humility because I know some things, but I certainly don't know everything. I think, instead of complaining and talking, I really decided to, really try to do and bring some of the, really what I feel very fortunate about some of the exposures I've gotten and the places I've trained, bring some of that to bear, within my institution.
Yeah, that's amazing. I mean, we see so many times where people just want to complain about things are not being done right. Why, I'm frustrated because things aren't being done right, but nobody wants to take the reins and do that and create, a way to have it done. It's
No, I
just,
think having agency. I think I'm a big person. That's one of my favorite words. I have a couple of favorite words, but agency is one of them. And I think, you could be in a place, a workplace, and, some people really try. They try to have agency and move the needle, and they're, cut off at the pass and stymied. But like, fortunately, I've had some doors open and some opportunities to be able to, like I said, move forward with things that I thought were good ideas and could make positive change along with other people and collaboratively. And so that's been really exciting.
Yeah, that is exciting. So you're the Associate Professor of Dermatology at the Icahn School of Medicine at Mount Sinai. So what does that role involve on a day-to-day basis?
What that looks like is, one is recruitment. And so I've been in that role since our new chair got there, and she really had a vision to try to scale and grow our department, especially around certain, subspecialties, build these centers of excellence. And so that required us really, getting out there and recruiting the best across the country to hopefully join our department. Mostly, I think they joined because of her. I'm involved in that process, vetting candidates, making sure that we're curating the right type of department. Also, once folks get here, they spend time in my practice to ideally learn, again, how to practice clinical medicine well. There is an art to it. There are, tips, tricks that make things go more efficiently. And hopefully when they're with me, I can, help them learn that. Also, we really help our new faculty through their process of onboarding. So especially that first year, we're checking in with them, making sure they're getting their needs met. They are seeing enough patients, seeing enough of them well, making sure that they're supported with everything they need. And then it's just the operational of the practice. So, that access piece that I talked about, that's more also outside of dermatology. But for example, things like our lasers, do we have all of the right, filters on the goggles, and how do we make sure we keep up with them? How do we make sure that folks are trained appropriately on lasers from a safety standpoint? Are we doing things that are in compliance with government regulations as well as hospital regulations and compliance? So it's kind of all of those, like our operation and administrative from a people standpoint and just a logistics standpoint, how we really get things done in our department.
So the students that are coming in, are they going into residency, or where are they at in the process?
So I have different students work with me, actually. Most on a regular basis, most consistent are going to be our residents who are currently in our department. And then we have medical students who are interested in going into dermatology who spend time with me. And then also I've had high school students, I've had college students work with me as well. But the most consistent are going to be our residents. And then just on a more casual, informal basis, I have a slew of mentees that I spend a lot of time with on the evenings and weekends, talking to them, reading through, as their personal statements for the application to medical school, kind of coaching them, even those that don't want to go into dermatology. I've been incredibly fortunate, and my goal is really to make sure that I set the next generation up to really lead impact and change. We need more doctors, in general, more good doctors. And so I want to make sure that I'm helping make opportunities for those folks to go to medical school.
Yeah. Do you see a lot of people that want to be in dermatology versus other specialties?
Definitely. The numbers show that. That's not just anecdotal. Like, the numbers show that it is one. I don't know exactly if it's the most, but one of like the top 5 most competitive residencies to get right now. And like I said, for all of the reasons when I led, I think people think it's fun. They see derms, there's a Dr. Pimple Popper show. So they see dermatology and plastics as like these fun, exciting, aesthetic careers, which they certainly are. Don't get me wrong. They are a lot of hard work. And I think with that fun, people are like, oh, like it's gonna breeze in, breeze out, pop some pimples, or but it's hard work. It's because, and I actually think many reasons why it's hard work, but one is, and that's something I have learned the longer I've been a doctor, patient care is hard work. It is. And if you're doing it well, if you're engaged, if you're making eye contact, if you're listening, if you are using empathy, it's hard work to see patients, particularly at the volume we tend to see them in dermatology. It's service. It's service. You're giving of yourself with every single patient exchange, and that can be very taxing.
Yeah, I'm sure. Just this month being Skin Cancer Awareness Month, and my company had put out a little fun fact Friday, and I was talking about melanoma being in areas that the sun doesn't even see, may not even
Yeah.
see. So stuff like that is, I think, is so amazing. And I was sharing it with my husband. And he's like, what? I didn't even know that. Like that's even, that can even happen, so it's really interesting how much information people still are not aware of. And patient education is huge. That is something really difficult, I think. Do you look for things when you've got residents and you're like, this may not be the specialty for you? How does that, how do you approach that?
Unfortunately, yes. I'll try to say it as delicately as possible. Look, I see this with residents. I see this with, faculty. I see this with medical students. Sometimes you're wondering, where the process broke that folks have gotten to this place and haven't pivoted. And I think that happens for a variety of reasons. My husband and I talk about it all the time. It's one of our recurring themes in our marriage, in our family, and with our kids. People just are not accustomed to telling the truth and having integrity about things. So I don't want to make this about dermatology. It happens in every, we read New York Times, Wall Street Post, New York Post articles all the time. How is it a person became the CEO and they were, abusing this one, all of this stuff, eventually sometimes there's fallout, but it's the human condition, people can get to very high levels, can get into incredibly competitive specialties and really not have gotten there, quote unquote, deservedly. They weren't the smartest, they weren't the kindest, they weren't the hardest working, and you're looking like, what happened here? And often I find if you dial it back, it's that people saw it along the way and didn't report it, or people reported it and the person they reported it to didn't want to do anything with it, wasn't highly motivated to, shut it down, just wanted to kind of get them off of their radar. And I think that happens a lot, which goes back to what I was saying, why I am passionate now to be in leadership, because I really do try to lead from that space of truth and honesty. And even if it's difficult, sometimes it's not popular. Just hush. They want you to hush. They want you to go along. They want you to look the other way at this and I wasn't really raised like that. It doesn't align with my goals and values. And so I think it's an opportunity to lead counterculturally, just lead in a way that's just different, because most folks don't lead that way.
Yeah, we need more of that. For sure.
Not always popular.
Right.
Yeah, no.
No, that's good though. So what does it really take for somebody to really thrive in academic medicine today?
So I'm going to answer this question in a few ways, not because this is what I've necessarily done. This is from mistakes, things I think I've done well, things I think I've done poorly. But the way I would answer this would be first, good support and mentorship, and really trying to find who that is and asking for it. I think that I probably was a person who I'm a hard worker. And so I just felt like, oh, you just work hard and you this and that. And that has been the case, like that in many aspects. I work very hard and people notice you and they appreciate your passion and your dedication and all the things. But then there's been other parts where I regret that I wasn't more intentional about asking XYZ person. I just didn't know. I was ignorant to certain things. I just knew medicine. My father's a physician, so I knew medicine. I watched him practice it, and I thought, not in an arrogant way, but I think I just kind of thought I knew, but he wasn't in academics. And so I would say the mentorship and guidance, that's number one. I would say that's top. And that can look like people in your department. Some of my best mentors are people who practice very differently. So outside of even academics, who are just older than me and have been in private practice and have a better scope. They have more perspective than I do. And so I would say that's really the key. Also trying to find the right fit. I think even if you have great mentorship, if you're not in the right environment, if you're at a place in academics that either is not supportive and that's become very clear to you through multiple things, or you just feel like the department is not going anywhere, just really trying to find, even if that means you need to go someplace else, try to find the right thing. And then the third is just making sure that it's aligned with your goals and values. I think people go into academics for a variety of reasons. And if you see after, I'd say about 5 years, that it's not the right fit for you, or if you're trying to be a researcher and you're not getting the grant or whatever, make a different choice. I think certainly you don't want to be fickle and changing ideas and thoughts with the wind. But I think there should be no shame in people kind of going back to what I said before about saying like, this isn't right. Like this person isn't a good fit, isn't a good leader, isn't going to be a good resident or doctor, whatever it is, or a good member of our faculty. I think there's no shame in just saying like, oh, I thought I liked academics, but I don't, and just do something else.
Yeah.
There's really no shame in that.
Learning how to pivot.
Yeah. Yeah.
That's true. I mean,
Yeah.
just in
There's
all
shame
walks.
in pivoting. There's a shame in the pivot. Like that's, it's hard. It's really, really hard. There can be a lot of shame. People just feel like, oh, like it's a failure or something, but not, but yeah.
Right. They got to figure out how to turn it into something good.
Yeah.
So what would you say to anyone that's interested in looking and wants to become a leader in dermatology, or just residents that are looking to teach?
Sure. As far as being a leader, you want to join certain organizations. So join, there's many, the ASDS, the AAD, there's a slew of different committees and leadership opportunities in all of these different dermatology. We have many of them, different dermatology organizations. So trying to be in leadership there, I think that's like a good stepping stone for being a leader. The other thing I would say is just to pace yourself. I find, so that's a balance. Like people are, they're anxious, they want to get there, they want to be a leader, a KOL. But, I always say you can't be a KOL if you don't have an O. You have to have practice. You have to you have to know medicine. You have to do it. Like I'm a better doctor than I was 10 years ago because I just have seen a breadth of cases. I've seen a lot. And so I would say, yes, be on that trajectory, get involved, but not so much that you're making yourself vulnerable because you're putting yourself in rooms or in environments where you just don't have the experience to really be in leadership. So having that humility and knowing that, there's a reason that it takes people sometimes 10, 15 years to get certain places because it just takes time. I think I see a little bit of that sometimes, people trying to get there in 2-3 years. And it's like, well, pump the brake, like
can't rush it.
You have to, get good first, get good, make some mistakes, get this, because you don't want to actually blow up on the scene and you're marketing yourself like that. And then, but you're not really that. You don't have the experience, the gravitas to really fill those shoes. So finding that balance.
Yeah. I've been seeing a lot more social media where, either they're residents or already doctors. Most of them I probably that I'm following are already doctors, but creating that social media following.
Sure.
But, I think that's, I don't know. What are your thoughts on that as a resident growing in that?
I mean, we have a particular philosophy about that at our department about residents doing a ton of that. But I think if you're in a place where they encourage that or support it, go for it. But again, I think you want to be mindful of how you're landing. Like you said, like you literally have not been out seeing patients yet. So yes, you can give some general advice. You have an MD, but I would say that you just haven't seen enough to really be out here. So if what you just want to do is say, hey, do like brand partnerships with a brand, and they're just looking for you because however large your following is, so they want you because of that. I think that's part of it.
Yeah. So as you are wearing multiple hats, tell me, how are you balancing that when you're even just in your own clinical practice?
Sure. In transparency, I believe in integrity and honesty about how it gets done. That's why all my social is very clean, practice focused. You may see, if you scroll back years, you may see like a picture of my husband or like my kid, because, if you're going to tell the good, you have to tell the bad. And I think that's way too curated. I'm mindful of how I'm messaging to other people, and, my life might make somebody else feel bad. Like I'm just very protective of something so sacred. And so the honesty of it is the way you get it done is a lot of paid help. We have an amazing person who helps us raise our kids, who's been with us for 12 years. I can't say enough about how critical that is. Somebody I trust immensely. I don't even have to think about it when I leave the house because, she's so wonderful. And our kids love her so much. There's that piece. We have some family help, but not, if you have that luxury, great. I hope to be able to do that for my kids. But that's not our situation. So, there are definitely some SOS moments. Family can step up, but, my parents don't live close. My husband's parents aren't overwhelmingly accessible. And so that's not, our situation. And so between the full-time person, we also have several other folks who we've known 10 plus years who just step up. And then community. So that's like the practical day to day, so the Ubers and the Fresh Directs and the, all the other things that make life, particularly in New York, we can walk places very, convenient. But then we also just have community, supportive community. From an emotional standpoint, you need people to come alongside you and to just help you get this done. Like who are your people? Who are your day ones? Who are you calling when, like this or that happened? That stuff you're not posting about on Instagram, which is why I don't like. I'm like, did they post how they were? Wait, because my 3-year-old just pooped in their underwear. Like, who posted that? Like all these curated. Like, I'm like, that's not the real. That's not. Did you see me in my head wrap like 5 hours ago? Like, come on. So I just don't, because I just think that gives just such a false perception of what's really going on, and we have a great life by God's grace, but, there's a lot of help that goes into this. Like, again, these folks even on these reality shows, again, maybe they are, but I'm like, are they showing the 4 or 5 nannies they probably have helping them raise all those 5, 6, 7, 8, 19 kids? Like, there's just no way. I'm like, if your hair is combed and your teeth are brushed and you got that many kids, somebody is behind that camera, somebody's behind that Instagram. Like, I just stop it.
Keep it real.
Full stop. So that's how we have a lot of help that maintains our sanity.
Yeah. That's funny. So along with all of that, you're also known for your commitment to patient-centered care, access, and innovation in dermatology. You're also the medical director of the Mount Sinai Doctors Patient Access Center.
Yeah.
Tell me a little bit more about that and what you're doing with that.
I've been doing that work about 7 years. Again, just an amazing opportunity. I came on, some leadership's radar screen, and they're just looking for someone to fill that role. At that time, access was really scaling and growing, especially access centers and academic medical centers. And this role of having a physician involved in that ecosystem, interviewed for that position, got it. And our access center has grown immensely. We have a great team. I really am part of that medical part of it. So our clinical training of our coordinators, when they're answering, helping make sure that physicians understand access and how to get patients in an appropriate time frame, understanding what we do, then our nurse triage. And so that's been really exciting. I have to say that is for sure an aspect of my career that I hadn't really thought much about and hadn't considered. I just have felt incredibly fortunate because it's exercised a whole nother part of my brain, given me insight and perspective into aspects of the health system that I wasn't aware of. And so that's incredibly exciting. Yeah. That's where I'm sitting right now in our access center on 42nd Street. We have like 400 folks here that are, buzzing, humming, answering our calls, triaging our calls, making sure patients get good care and get scheduled appropriately.
Mm-hmm. When it comes to access, why was there a need to have you involved in that? And do you think that is necessary for a lot of doctors to be aware and understanding of what it takes when it comes to access and the details, I guess?
No, absolutely. So I think, again, about probably around the time I got this job, that conversation was starting, because it used to be pretty much, it was operational administrative folks that ran access centers solely, without any kind of clinical oversight. Sometimes there would be nurses that were in some of those roles, but it wasn't physicians. And, I think that there's a lot of a branding management that goes into access, because people hear call centers and oh my gosh, da, da, da. But I'll be honest, I am not just because this is the work that I do, but I'm a 110% believer. I get it that patients get better care this way. There is an excellence and a discipline to doing it and doing it well. And they're going to get better care here as opposed to someone at the front desk who may call out or who may this or that, answering your calls, not at scale. If you're a solo practitioner with a very niche practice, great, knock yourself out. You got your mom or your brother at the front desk answering for you, great, your call volume is low. But high call volume or managing even something like COVID, you've got major pandemics, things like that, patients calling frantic, you just can't do that without a pretty large operational machine. And so, bridging that gap between, what we're doing here and helping physicians understand that work, I think that's actually a big part of it. I meet with them, I talk to them about access, get that ongoing. So that's really the main reason why. It's really also just an understanding and a cooperation, because we can't do what we do well here without the physician buy-in and their help and understanding what is your practice, what are your needs, how do you want your calls triaged. If they're disengaged, we can't get what patients need. And that's ultimately what we want, is the excellent patient care.
Right. Yeah. I mean, patients leave the office and they forget a lot of what was
Yeah,
told to them.
I know.
So
I know. Like,
they're
oh
like,
yeah.
wait, where's that prescription going to
Yeah,
be? You sent it
exactly.
in, right?
Exactly,
What do you
exactly.
mean a prior authorization?
I know. No, and that's huge. Like even understanding that, like we created a getting your medication sheet in our practice. There's just so much there that it's so important.
Hmm. Yeah, it really is. I mean, that is something a lot of times I feel like gets missed,
Hmm.
when it comes to the patient access side. We
Hmm.
think of, oh, it's just a prior authorization, just send it over
Hmm.
to get approved and
Hmm.
then that's it. But when
Hmm.
it comes to a lot of these specialty
Hmm.
medications, there's so much more that's
Hmm.
involved with it, whether it's
Absolutely.
patients making sure that they're getting their labs done or just
Hmm.
teaching compliance to patients and helping them understand that, yes, this medication can work and can help and make a huge impact in your life. But if you're not coming back in for your follow-up appointment, or you're not making sure that you're getting your labs done when you're supposed to, or calling the
Exactly.
pharmacy or answering, calls, like there's so much little nuances that go into it.
Absolutely. Yeah, and our coordinators need to understand that work.
Mm-hmm.
They really have to understand that in order to, again, help the patient navigate. Like that's what I really see it as, like navigation and coordination.
Mm-hmm.
It's all of that. And, what we're doing here really helps them get them their care. Like
Right.
it all goes together. It doesn't matter. You can write the best biologics, but if somebody can't get it and doesn't understand how you go about getting it,
Mm-hmm.
then you've really lost.
Yeah. Do you think patients have a perspective when it's a hospital setting versus going to a smaller private practice?
Mm-hmm. No, I can speak for, so I've practiced in Boston, Minnesota, and New York, and I
Mm-hmm.
can speak for patients kind of in all of those environments. I do think people sense and feel, and the feedback I get anecdotally in my practice, that they're getting better care in these environments. I don't know if it's how the facilities look. I
Mm-hmm.
don't know if it is just, again, the way we present, like how, all of our soup to nuts. So how people are dressed there, the uniform, all of that.
Mm-hmm.
They really do feel like they're getting better care. And I can just attest, and I know I'm biased, but, just access to clinical trials, things like that. Like we have that access for them to really, in my mind, get them the most cutting edge care. Are they,
Mm-hmm.
getting substandard care in a private practice? Absolutely not. But I think, especially in certain environments, especially places that have poor access to physicians, they just may not have the exposure to some of the
Mm-hmm.
newer medications. Like it takes time sometimes to get it out there
Yeah.
in the vapors. And so I think that's a big piece too, is that we just have a machine, frankly, that can get this done. Even from our prior authorizations, we have, built-in biologic coordinators basically into our operations for dermatology, oncology, several specialties. And so
Mm-hmm.
there is just my husband, just had an experience where he got a medication like from that workflow. And I even saw on that side, oh wow, it's like super fat.
Mm-hmm.
They just have it a well-oiled machine that probably in a private practice, it's challenging.
Yeah. I think that's such a good thing too for residents, because I
Mm-hmm.
mean, how much of the prior authorization and access process are they
Mm-hmm.
learning in
Yeah.
med school? Are they
Mm-hmm. Not
mostly
much.
getting that hands-on
Oh my gosh,
experience?
no! I never knew it. I never learned any of it. Like I can't. I mean, even in my residency, it wasn't until even during residency. No, it wasn't until I was out practicing that I
Mm-hmm.
really, really saw it. Mm-hmm.
Yeah, that process isn't really taught. It's just,
Mm-hmm.
hey, you got to deal
Yeah.
with insurance, and this is what you
Yeah.
have to do. But they
Yeah.
don't share, this is what's needed in the notes, and this
Exactly.
is how,
Exactly.
how is that taught, I guess, with your residents? How are you
Sure.
teaching them when there's specific things, say a new drug comes on the market?
Mm-hmm.
How do you
Mm-hmm.
educate them
Mm-hmm.
on what they need to make sure they have in
Sure.
the notes in order to get stuff approved?
Okay. So we do that, ultimately by making sure our resident clinics are staffed with people, with our faculty who can really teach them. Then they're, of course, spending time in faculty's practices. So it's not just our residency practices, but also they're spending time in a physician, one of our attending practices. And so that's really how they learn. It's on the job. I mean, ultimately, a residency isn't like an apprenticeship at a,
Mm,
at a high level. And so they're learning those pieces as well. And then in our department, we're very intentional, as I mentioned, about making sure when people onboard onboard, they spend a couple of days in my practice where they're learning, okay, how do I document this? Because not everybody trained at Sinai. So, how do we do it here in our EMR, with our group of medications, our formularies? And I think that's what's critical.
Mm-hmm. Yeah, it is critical. That's awesome, though. So you have a philosophy as medicine as an art. What does that mean? And how do you bring that into a clinical setting? I think that's pretty cool.
So my little tagline is, I view medicine as an art that should be practiced with integrity. The integrity piece we've spoken a ton about. Like, it's just a single thread kind of through everything that I really try to do, from soup to nuts, between how, we're treating office staff to how patients are treated. It's hard to compartmentalize those. As much as, AI tools and technologies, I'm actually excited about those as far as like diagnostics, but you would still layer over that the art, which goes into the years and years of training. Like, for example, I'm a much better artist now than I was, as I mentioned, 10 years ago or even 5 years ago, because I've seen more. It's pattern recognition. It's okay, well, I've tried this treatment 10 times and didn't work, 2 of the 5. So like, let me try something else. And I think that's really how I view it as an art, is that it's a constantly evolving pulling together of all of the things that the new technologies we're learning, seeing more patients, understanding how to integrate that into the patient in front of you. And, that's really how I kind of came up with that little tagline.
I like that. But you've also said that you think patients should recognize themselves after cosmetic treatments.
Yeah, no, that's the thing. I mean, look, I'm big on that. Like, I do cosmetics. I enjoy it, but I've probably definitely lost some patients because I'm not willing to distort somebody's face. I'm not willing to do something to them they really don't like. I mean, you're always going to have the occasional cosmetic patient that is unhappy with you. That happens to any good doctor. Like, somebody doesn't like their technique. We make it right. We fix, we this, we that, but never to the point where I feel like, oh my gosh, I pumped so much filler in your face, or I did something to you where your friends and family wouldn't be able to recognize you. And because I mean, look, there's a lot of that out there. We see it on TV. The Met Gala just happened, and all the award season, and it's unfortunate. People who are like, this doesn't even look like the same person.
Yeah.
And look, I don't have any issue doing those procedures. I'm not a purist that's like, no, I don't believe in. Of course, I believe in it for my patients, for myself. Yeah, of course, I'm doing some procedures, but it's with what hand? A subtle hand, just trying to enhance, not to distort. I think that's what's really at the crux.
Right.
Yeah.
So speaking of cosmetic, what are some of the trends that you dislike?
Trends. I have to say, and I just will probably have to get over myself, but I don't love trends of these like fly by night clinics. Like, there's a lot of them coming up. I'll leave them nameless, where like, folks that are not MDs are doing injectables, and I don't love those. And I fix some of that work too. People like, oh, I went to insert X new branded place. And so they get in there, they teach folks that are not MDs how to do them. Like, there's a whole training program on how, like, there's a lot of these are well-oiled, PE backed machines where, it's folks that just haven't gone to medical school. And I don't want to take anything away from, folks that are not MDs who are practicing, medicine. But I do think I would recommend you leave injectables to MDs. So, and ideally dermatologists and plastic surgeons. Okay. Yeah. Injectables, lasers, that really shouldn't be done by someone who didn't, in my mind, who did not go to medical school for a variety of reasons. Yeah.
Right. Yeah. I mean, that would make the most sense.
Yeah.
So what are some trends that you like that you're seeing?
Trends that I like. I mean, I think more patient awareness. This is where the internet has been great. Like, I actually like, some doctors don't like it, but I love when patients come in, like, I read this on Reddit. What do you think, Dr. Lamb? I like that they're at least doing some research and then asking me to vet it.
Yeah.
So I think it's great. I think patients just being more educated, aware, having, again, that agency like we talked about earlier. I think that's amazing. Not saying I did go through a rigorous training and I know a lot. I think where having the MD, the expertise comes in is you can sift through some of that knowledge, like a lot of things out there based on, double-blinded placebo-controlled studies, clinical trials, and that can be hard to pick apart if you, I mean, frankly, if you just don't have the scientific training, it's a different language. And so I can look at, screen some of that information patients are coming in with and say, oh, but it's this, it's that. I can unpack it for them. But I do like that they have it. So I like that actually.
Yeah. I mean, it is true. I hear a lot of mixed, I guess, from different people in the industry about, oh, patients see these commercials on TV and then that's what they come in and they ask for and they don't really understand. But I mean, that's, in a way, it's kind of good and bad. You can, it's a learning tool. It's a teaching session for the patient. Yeah. So you're like, oh, I think I need this medication. This is, are you self-diagnosing?
Exactly. No, exactly. It's if they're self-diagnosing, different story. And then sometimes if I feel like they've read something and they're not being I say, well, so what do you think you have? Or what do you think? It really should be a democratic process. It should be shared, what we call shared decision making. It is shared. I really like to practice that way. Yeah. Shared decision making. And I think, I don't think there's been studies on this, but when there are definitely studies that show that when patients feel seen and heard, you get better outcomes. And I think the more we do shared decision making, the more people will buy into what we're telling them. They're going to use the medications. How many people come to me like for a second, third opinion because they're like, oh, the other folks I went to weren't listening to me. It's hard to buy into a treatment, especially a high risk treatment, like some of the biologics, like the work you do, if you just think the doctor that you don't even trust. How are you going to take a medication with truly some of these do have some serious potential side effects if you don't even trust the person that is writing it for you. Like that's a big piece of it. And I think the way you build that trust and gain that trust is some of that shared decision making. Let's discuss it. Like often even with biologics, I'll give them a few choices.
How long?
I have them leave the office and we come back. I say, hey, these are a few I'm thinking of. Why don't you read through? And then next time we'll make a decision.
Yeah. How long do you have like your, I guess, consulting or just conversations with patients? How much time are you spending with them?
So I'd say usually between 5 and 10 minutes.
Okay.
That's about how much time we have, about 5 to 10 minutes. And often I think that's enough. That's enough. If you're sitting, if you're listening, if you're also open to questions after the visit. So we, unlimited questions you can ask me through our, my chart portal. I'll answer you. My assistant will answer you. I think that tends to be enough. That sounds like, it's funny. So someone listening to this might be like, that's not enough. But they have probably if they've come to me as a patient, if you time it, it's been 5. It feels like longer because I'm sitting and I'm listening and I'm hearing you. But often you don't need much more time than that to answer most questions that people have about a treatment plan or side effects.
Yeah, that makes so much sense. I mean, I think when you go into an appointment, and that's where a lot of patients, they come in and they think, oh, well, these appointments, it's so crazy. They're so short. We don't ever have enough time with the doctor. But if you're spending that time wisely and having those conversations and listening to the patient versus coming in and, maybe not even really answering those questions, just talking, just saying, hey, this is what you need to know. I mean, I've been on both sides of that. I've been in an appointment, same amount of time where I feel like I've had a really good conversation and I've got all my questions answered and I feel heard. But then I've also had a, appointment where the doctor came in and it was just them talking and then, okay, well, that's it. And then I felt like, wait, I didn't even have a chance to think about a question.
Exactly. I know.
Right. Like I'm trying to take in all the information that you told me, but I don't even know, give me a second so I can think of what my question is.
No, I totally agree. I mean, it's challenging. And that's where as physicians, we have tough decisions to make because it's hard. We still are in a system in this country where the more patients see, the more money you make. And even I had to do some soul searching. So what does that look like for me to not see 50, 60 patients? That's not sustainable. For me, at least, I wasn't feeling sometimes like I was giving good care. You just don't have enough time because your margin is so small. If you run over with one person, then your whole day, then you're like 45 minutes, an hour late, so there are all these moving factors. And then you just decide, so does this mean perhaps you take less insurances, you do more cash, but, so there were different ways I had to really restructure my practice in the last year or so, just to be mindful about hey, what does that really look like for me to be able to spend the time I I want to spend with patients and keep our lights on. As a mentor once told me, no money, no mission, because these are just practical aspects. You do have to make some money. We have overhead, we have salaries in our office to pay, we have lasers to buy, all of the things. But also just not be so rushed and so pushed to be able to meet that metric. Yeah.
Yeah. No, that makes sense. Well, it's been such a pleasure talking with you. I feel like I've learned so much information, but it's so amazing the work that you're doing and educating and teaching and leading the next generation of doctors. And it's so inspiring. So I really appreciate that.
This is really a pleasure, a true honor. And especially with you, who really is, out here working, scaling to get patients much needed medication. So this is a great kind of a collaboration because our passions are aligned.
Absolutely.
Yeah.
Thanks for spending a few minutes with me and listening to That's Derm Good. You can expect new episodes of That's Derm Good every week. The podcast is available on your favorite app, including where you're listening right now. Subscribe to the podcast so you never miss a new episode. Bye.